The sensory pathway, the ascending spinothalamic tract. This is the structure of the spinal cord. Says this gray color is a gray matter, H-shaped or butterfly shape, and these are the white matter, posterior, lateral and anterior. Entering into the spinal cord are the nerves, the anterior and the posterior spinal nerves. They both have sensory and motor fibers here, but then this one over here, anterior one, contains only the motor fibers, and the sensory or the dorsal root contains the sensory fibers. The anterior root, the anterior spinal nerve here, the root, it starts from here, the anterior horn cell of the spinal cord. These anterior horn cells of the spinal cord, they are diseased in polio and cause lower motor neuron type of paralysis with muscle weakness, paralysis, hypotonia and denervation, hypersensitivity. The posterior root joints brings the information from skin and muscles to the posterior horn. This is the other picture, and this one includes, this is where my arrow is, sympathetic chain, and this is sympathetic ganglion, and this one. If you see that the nerve carries both sympathetic fibers also, these are the sympathetic fibers, they're here and they relay into the sympathetic ganglion. These fibers, they come in the spinal nerves. This is the afferent. See it, if you follow the cursor, it goes from here and then to the sympathetic side. Similarly, if you follow this in, the blue one is the sensory one, sympathetic, and this, if you follow, it goes here, and this one will join the posterior or the dorsal root. There are two types of ascending sensory pathways, the spinothalamic tract and the dorsal column tract. This is the picture I've made it to make you understand. From this is the spinal cord, these two are this is the spinothalamic tract and this is the dorsal column tract, and then this goes up the spinal cord, and this is the medulla where the dorsal column relay, and then this is the thalamus where both of them, the spinothalamic and dorsal column relay in the VPL, ventro-posterior lateral nucleus of the thalamus, and posterior lateral nucleus of the thalamus, and from the thalamus the third order neuron arise and they travel up to the sensory cortex of the cerebral cortex area 312 of the Brodmann. The thalamus is the great sensory relay station. All sensory fibers relay there, but it doesn't mean that it doesn't have the motor fiber. It does have the motor fibers as well. The first order neuron are in the dorsal root ganglia at all level, and they project to the spinal cord, and then the second order neurons are found in the dorsal horn for the lateral spinothalamic tract. Then they decussate and cross over to the opposite side. See that this is the spinothalamic tract. I made a picture to make you understand that they cross over to the opposite side. They relay here in the dorsal horn and then cross over to the opposite side. This is the spinothalamic tract, and then it travels up to the thalamus where the third order neuron arise, and then they project to the Brodmann area 312 sensory cortex. To the spinothalamic tract, the dorsal column fibers, they do not cross over when they enter the spinal cord, but instead they travel up in the white matter in the spinal cord until they reach the medulla. The fibers from the upper limb, they travel in the fasciculus cuneatus, and fibers from the lower limb, they travel in the fasciculus gracilis. Both fasciculus cuneatus and fasciculus gracilis, they relay in the lower ventromedial part of the thalamus. The rostral or the caudal ventromedial portion, they relay in the medulla, and then after relaying in the medulla, these fibers from nucleus cuneatus and nucleus gracilis, they cross over to the opposite side. See that they're crossing over, and they travel up in the medial laminiscal system to the thalamus to relay over there, and from there VPL nucleus, the third set of neuron rise and relay in the Brodmann area 312 of the cerebral cortex. So the first order neurons are in the dorsal root ganglion, and they project to the spinal cord. The second order neurons are in the dorsal horn. The second order neuron decussate and cross over to the opposite side and relay in the thalamus. And the third order neuron from the thalamus to the area 312. The two types of ascending fibers is spinothalamic tract and the dorsal column. What type of fiber the spinothalamic tract carry? They carry pain, temperature, crude touch, and firm pressure. What sensation the dorsal column fiber they carry, or the posterior column? They carry fine touch, pressure, vibration, and the proprioception. Many layers in the dorsal horn. The dorsal horn is divided into 6 layers. Layer 1 to 6. Layers 2 and layers 3 make up the substantia gelatinosa, and substantia gelatinosa is concerned with pain through the gates. In the gates theory, the touch fiber, they connect with the pain, and the pain is a nociceptive, is an unpleasant feeling. They don't want to travel it up. So the touch keeps it preventing going up. This is the gate theory for the pains. The transmitters released are substances P and somatostatin. To the spinothalamic tract they travel. There are two types of spinothalamic tract: the anterior spinothalamic tract and the lateral spinothalamic tract. The anterior spinothalamic tract carry crude touch and firm pressure sensation, and the lateral spinothalamic tract that carries the pain and temperature fibers. This is the section of the spinal cord that shows the arrangements of different tracts in the spinal cord. If you see that this is the anterior spinothalamic tract, which carries the fiber for pressure and a crude touch, and this one, if you see in the lateral horn, is the lateral spinothalamic tract that carries the fiber for pain and temperature. So the anterior spinothalamic tract is anterior to the H-shaped sulcus of the greyhound, and the lateral spinothalamic tract is in the lateral white matter. Why? Because these fibers, the second order neuron, they cross over at the spinal level, and if you see the arrangement of fiber, the most lateral is sacral for both of them. See, in the anterior spinothalamic tract, and the most medial are the cervical fibers represented by C, in both lateral spinothalamic tract and anterior spinothalamic tract. If we go posteriorly in the section, you see the dorsal column here. These fibers is the sacral is the most medial, and the cervical is the most lateral in the dorsal column. We'll come to discuss this later. And this one here, it is the pyramidal tract, which is in the lateral horn of this white matter. The arrangement of spinothalamic tract fibers in the sacral and lumbar region. So the spinothalamic tract fiber, they cross over in the spinal cord when they enter into it. So the fibers from the lower region, that is sacral and the lumbar region, they are pushed laterally by the fibers from the higher center. So the cervical fibers are most medial and the sacral fibers are lateral, and this is because they cross over in the spinal cord. Compared to this, as I showed you the picture of the posterior column, in the posterior columns, the sacral fibers are most medial and the cervical fibers are lateral, because these fibers, they travel up ipsilaterally in the white matter up to medulla. So in the fibers from the sacral and lumbar region in the posterior column, that is the fibers for the fine touch, pressure, vibration and proprioception, their most medial fibers are cervical, and the lateral cervical are lateral, and the sacral are the most medial fibers. So in the spinothalamic tract, the cervical fibers are medial and the sacral fibers are lateral. But in posterior column, the sacral fibers are most medial and the cervical fibers are lateral. This is very important clinically. The tumor that arises outside the spinal cord will first affect the pain and temperature fibers in the lumbar and sacral area, whereas the tumor inside the spinal cord will produce anesthesia in higher segments. So if you see the cut section spinal cord here, this is the lateral spinothalamic tract and this is the anterior spinothalamic tract, and they have the sacral fibers outside. So it's a tumor which is outside here, it will affect the sacral fibers first and it will produce anesthetic patches there in the sacral region first. But if the tumor arises here and you see the cervical fibers and medial, so tumor inside will affect the cervical fiber, leading causing anesthesia here. Similarly, this is the pyramidal tract here, and their arrangement is same. The sacral is outside and the cervical are medially. So outside tumor will press on the sacral fibers first. So there will be motor deficits in the sacral fibers first, and in case of intramedullary tumor, the problem will be in the cervical area first. As opposed to this, if you see the posterior column, in the posterior column the sacral fibers are the most medial and the lumbar, and the cervical fibers are the most lateral. The sacral and lumbar, they are from the fasciculus gracilis, and the cervical and thoracic, they are coming from the fasciculus cuneatus, which is lateral. The sensory areas in the cerebral cortex. There are two sensory areas in the cerebral cortex. Sensory area 1 is in the sensory cortex, which is behind the central sulcus. The sensory area 2 is in the wall of the sylvian fissure in the lateral cerebral sulcus. How big is the area of representation in the cerebral cortex? The more the receptor an area has, the bigger the cortical representation. The fingers, lips, and mouth have bigger area because they have more receptors. The lesion of the post-central gyrus decreases but does not abolish sensations. And what sensations are gone first and which one last? The proprioception and fine touch, which are carried by the dorsal column or medial laminiscal system, are most affected by the cortical lesions, and pain is least affected and returned first. The proprioception and fine touch are last to return in case of cerebrocortical lesions. Let's discuss the touch sensations. How the touch sensations are carried. The touch is carried in two pathways. The anterolateral spinothalamic tract that carries the crude touch, and the laminiscal system or the posterior column that carries the fine touch. Where are the touch receptors present? In the hairy area, they are present around the hair follicles, and in the hairless area, the touch receptors are present in the subcutaneous tissue. The Pacinian corpuscles, which are the touch receptors, are found in subcutaneous tissues, but they are also found in muscles, mesentery, and joint. What type of fibers carry the touch? Two types of fiber carry touch, but mainly the touch sensations are carried by group 2 fibers, which are 5 to 12 micron meter in diameter, and the speed is very high, 30 to 70 meters per second. And second type of fiber that carry the touch are the C fibers. Only very extensive lesions completely interrupt the touch fibers. In the dorsal column lesions, touch threshold is increased because they carry the discriminative touch sensation, so the threshold is increased and localization is poor. Whereas in a spinothalamic tract, which carry the crude touch, the touch decreases slightly and the touch localization remains normal. So the main carrier for the touch is laminiscal system, which carries fine touch and at a very high speed. The lesions of the post-central gyrus lead to loss of fine touch on the opposite side. What is two-point discrimination? The two-point discrimination test is the combination of touch and the cortical component of identifying the objects. It depends on the number of touch receptors. If the touch receptors are more, then the 2 point which will discriminate will be, the distance will be less. Say for example, on the fingers there are too many touch receptors, so the distance is 3 millimeter compared to the back where the 2 point discrimination is 6 to 8 millimeters. What is stereognosis? Stereognosis is the ability to identify objects in its texture with closed eyes and with one hand. It depends on the touch and pressure sensations and cortical component. The patient is asked to close the eyes and a coin is given in his hand and asked to recognize the coin. Impaired stereognosis is an early sign of damage to the cerebral cortex. Lesions in the parietal lobe posterior to the post-central gyrus produce stereognosis without defect in touch and pressure sensation. So it's very important that if there is a lesion in the parietal lobe posterior to the post-central gyrus, it causes stereognosis, but there is no defect in touch and pressure sensations, but the patient becomes unable to recognize the texture and the shape of the object. This is known as stereognosis and is a feature of the lesion in the parietal lobe posterior to post-central gyrus. The proprioception. The proprioception is transmitted through the dorsal column or the medial laminiscal system to the sensory cortex. The dorsal column carries proprioception, vibration, fine touch, and pressure. Many of the fibers, they go to the cerebellum, and the dorsal column defects and the cerebellar diseases, they produce ataxia. What receptors are responsible for the position sense in this space? It is the Pacinian corpuscles that are responsible for that. The conscious awareness of the position in a space depends on impulses from Pacinian corpuscles in the joints, synovia, and ligaments, and not from the Golgi tendon or muscle spindle from the muscles. Vibratory and proprioceptive senses are damaged together, and remember, the proprioceptive senses are last to return in case of cortical lesions. What are the receptors for vibration? The receptors for vibration are touch and pressure, especially the Merkel's test. What are the conditions where vibration sense is lost? The vibration sense is lost in diabetes mellitus and in vitamin B12 deficiency, where the posterior column defect and patient loses the positional sense. The temperature. The temperature travel in the lateral spinothalamic tract with the pain fibers. The temperature are of two types, the cold spots and the warm spots. The cold spots are 5 to 10 times more than the warm spots. The temperature fibers are the naked nerve endings that responds to absolute temperature. From the naked nerve endings, the afferent arise. These are small myelinated fibers of 2 to 5 micron in diameter. Below 20 degrees C and above 40 degrees C, there is no adaptation, and at more than 45 degrees centigrade, the damage begins and sensation becomes that of the pain. The pain fibers. The pain is conducted through the lateral spinothalamic tract. How many fibers they carry the pain fibers? There are two types of the fiber that carry the pain. The A delta fibers, which are fast conducting and myelinated, and the C fibers, which are slow conducting and unmyelinated. The diameter for the A fast fibers is 2 to 5 micron meters, and that for the C type of fiber is 1 micron meter in diameter. The A type fiber go in the lateral spinothalamic tract, whereas the C type of fiber, they are found in the lateral division of the dorsal roots and are often called the dorsal C root fibers. The A fibers end in the dorsal horn layer 1, whereas the C fiber, they end in deeply in the substantia gelatinosa and the layer 4 and 5. The A fiber conduct sharp and localized pain as the pinprick, and the C fibers, they conduct dull, diffuse and intense pain. The surgical procedure anterior cordotomy is done to relieve the pain, which cuts the pain fiber in the lateral spinothalamic tract. The second set of neuron for the pain, they go up to the ventro-posterior lateral nucleus and posterior lateral nucleus of the thalamus, and from there on they pass through the posterior limb of the internal capsule to the cerebral cortex. So all these sensory fibers, they pass through the posterior limb of the internal capsule, whether spinothalamic or the dorsal column tract. There are no pain fibers in the dorsal column, but section of the dorsal column makes the pain sensation worse. And another important interesting point is that the sensory stimuli are perceived in the absence of cerebral cortex. What is thalamic pain syndrome? The blockade of the thalamo-geniculate branch of the posterior cerebral artery damages the posterior thalamic nuclei that cause prolonged and severe pain. What surgical procedures are carried out for severe pain relief? In cancer patients who have severe pain, in them a prefrontal lobotomy is done, and that prefrontal lobotomy converts severe pain to a tolerable pain due to deep connection dissociation, but it causes the personality changes. What personality changes it causes in frontal lobotomy? Number one, it converts an aggressive patient to a quiet patient, but the incentives are lost, personality is completely changed. The other procedure done to relieve pain is the anterolateral cordotomy. What is anterolateral cordotomy? This is done in the spinal cord, and it cuts the lateral spinothalamic tract pain fibers. It does not affect the touch because it is also carried by the dorsal column. So cutting the anterolateral spinothalamic tract in the spinal cord relieves the severe pain, but it does not affect the touch fiber because they are carried, the fine touch is carried by the dorsal column. How is the deep visceral pain? Deep pain or the visceral pain, it is severe, poorly localized and accompanied by changes in blood pressure, and there is a reflex muscle contraction over that area, and this is known as the guarding. What is important about the pain receptor is that they are pain specific. That is, the pain receptors are specific and it cannot be produced by stimulation of other receptors. What are the stimuli to which the pain receptors respond? The pain receptor responds to electrical, chemical, and mechanical stimuli. What are the chemicals that causes the pain? The chemicals that cause pain are kinins, histamine, substance P, and potassium. So these are the chemicals: kinins, histamines, substance P, and potassium. Angina is a classic example of accumulation of substance P. Rest removes the substance P and relieves the angina. And the same phenomena occur in occlusive vascular diseases, which are relieved by the rest. So angina and occlusive vascular diseases are relieved because the substance P, which accumulates, is removed. The pain receptors are present in viscera, but no proprioceptors, and only few touch receptors are present in the viscera. The visceral afferent travel. The visceral afferent travel through the spinothalamic tract. The thoracic and abdominal viscera receive pain impulses by dorsal T1 to L2 nerves and also by sympathetic nerves. That is why sympathectomy abolishes pain in heart, stomach, and intestine. So this is the third surgical procedure that abolishes the pain. Number 1 was frontal lobotomy. Number 2 was anterior cordotomy in the spinal cord that cuts the pain fibers. And number 3 is the sympathectomy that abolishes the heart, stomach, and intestinal pain. Inhibition of pain by the gates in the dorsal horn is due to the impulses carried by the touch fibers in spinothalamic tract to substantia gelatinosa, and that inhibits the pain sensation to go to the spinothalamic tract. So the touch fibers, they stop the pain fibers because it's a nociceptive. It is an unpleasant feeling, so they don't let it go up into the spinothalamic tract. This is the gate theory for the pain, and it occurs in the substantia gelatinosa. The itch. How the itch is carried? Itch is carried by the C type of unmyelinated fibers, which are slow conducting fibers, and they go through the spinothalamic tract. The itch is abolished by section of the spinothalamic tract. Itch does not occur in the viscera. What are the chemicals that produce itch? The chemicals that produce itch are kinins and histamines. What plant chemical produces itch? The powder from plant cowhage liberates a itch peptide. The sensory fibers from the head. The sensory fibers from the head joins the laminiscal and spinothalamic tract in the brain stem. It is the trigeminal nerve that carries the sensory fibers from the head. The trigeminal nerve has two nuclei. The spinal nucleus of the trigeminal nerve carries pain and temperature fibers, whereas the main sensory and mesencephalic nucleus of the trigeminal nerve carries touch, pressure, and proprioception. The spinocerebellar tracts. The two types of spinocerebellar tracts are anterior and posterior spinocerebellar tract. They run ipsilaterally to the cerebellum. The spinocerebellar tract ascends in the lateral funiculus and ascends in the posterior horn to synapse in the cerebellum. These spinocerebellar fibers, they carry impulses of proprioception from the same side of the trunk and the lower limb at the subconscious level. Some more points about the sensory fibers. In unilateral lesions, the level is 1 to 2 segments below the level of lesion. But in bilateral lesions, it starts at the level of the lesion. The sensory fibers synapse in the dorsal horn, and then they ascend ipsilaterally for several segments before crossing to the opposite side. The acute transverse lesions are followed by brief clonic or myoclonic movements of the limb. What are the fibers that travel ipsilaterally? The fibers that travel ipsilaterally are the posterior column fiber. They travel ipsilaterally up to medulla with the relay in the nucleus cuneatus or gracilis. The spinocerebellar fibers, anterior and posterior, they also run ipsilaterally. And the pyramidal fibers, because they are coming down from after, they cross over in the medulla and in the spinal cord, they go to the ipsilateral side. The fibers that travel contralaterally, they are pain and temperature fibers and that of the crude touch.